I extend warm welcome to our faculty delegates who have logged in from all over the world. This is the fifth series on the. I am Dr. T.S. Chandrasekhar for the delegates who have logged in from abroad. I just want to introduce myself. I am the American College of Gastroenterology Governor, India region. I bring warm greetings from American College of Gastroenterology as a member webinar subcommittee and from the World Gastroenterology Organization as a member scientific committee and from the Tamil Nadu Dr. MGR Medical University as its honorary distinct professor. And I bring further greetings from our institute, Medindia Hospital and Academy, who have been organizing this kind of webinar. First four series of international webinar endorsed by American College of Gastroenterology saw the participation of over 19,000 delegates from all over the world. That really inspired us. Why not we start the next series, fifth series of the webinar? We give the catchy title, name the topic the world experts are here. That is really true. And we gave the another very catchy thing is news. We are just talking about news. There's another endoscopy procedure here. New Endo-GE webinar series is a news. And this series have been inaugurated by none other than the Professor Dr. Jonathan Lighton, who was the president of American College of Gastroenterology. And after that, we have done over 36 international webinars on gastroenterology, endoscopy, and hepatology. One of the webinars witnessed the participation of we were lucky and we were really inspired by lecture by Nobel Prize winner, Professor Dr. Barry Marshall, who is the discoverer of Helicobacter pylori, which revolutionized the management of peptic ulcer and stomach ulcer. He gave a very inspiring talk on the journey of discovery of Helicobacter pylori and further. After that, we have seen most of the president of American College of Gastroenterology and who is doing gastroenterology from USA and rest of the world have participated in our webinar. These webinars have been possible with coordination from my colleagues, Dr. Gokul, Satya, Rajayogesh, Prasad, and Trinyana Sambandam. And this was really successful because of the participation of the galaxy of stars, national and international. And you name whoever has done the original work in the field of GI and endoscopy and hepatology have been our faculty, and ably moderated by the who is who, the middle level, the gastroenterology, eminent gastroenterologist from India, and the panelists from various parts of the world. Now, this time we have the fifth series. We have scheduled from April to October. We are going to have the first webinar on neuroendocrine tumors and GIST, gastrointestinal stromal tumor. And next month we are going to have selection and optimization before liver transplant and post liver transplant care, a physician perspective. Then diarrhea in immunocompromised hosts, irritable bowel syndrome, art and science of management. And further in July, how did I arrive at the MELT score by Dr. Patrick Thomas and clinics in alcohol-associated liver disease, second by the same faculty. Ulcerative colitis management in 2026 and Crohn's disease management in 2026, followed by dysbiosis and GI diseases and antibiotic right choice and rational in GI infection, pancreatitis and liver diseases. And finally in October, in acute pancreatitis, natural history complication management and chronic pancreatitis by various faculty from all over the world. And we are fortunate to always get the Tamil Nadu Medical Council credit hours for this. And this time we are going to have two very important topics. Just now before this webinar, the Gokul were discussing, are we diagnosing more properly, or there is an increase in the incidence of neuroendocrine tumor urges, or diagnostic modality has improved so that we are able to see this. So we have eminent speakers and moderators. I have a great pleasure in introducing my faculty, Professor A.S. Puri. He has been the professor in HOD. I wouldn't like to say retired. He has been the past professor and the HOD Department of Gastroenterology, GB Pant Hospital. He seems to be more active after retirement also. He is the Vice Chairman, Institute of Gastrosciences, Medanta Hospital, New Delhi. He has got a varied interest but is focused on luminal gastroenterology, IBD, and celiac disease. And he's a very passionate speaker and he prepares so well. He's a great teacher. He is authored of over several publications with a good H index. And next, I want to introduce Matthew Philip, who is going to moderate. He is the Chief of Medical Gastroenterology. Sorry for the spelling mistake. Head of Department of Lyceum Hospital, Kochi. Honorary Secretary General of Indian Society of Gastroenterology. He is also has got varied interests, but mainly focuses on therapeutic endoscopy in IBD. He has been the invited faculty to various national and international conferences. The next speaker is Professor Dr. Sridhar Sundaram. He is a professor, Tata Memorial Center, Mumbai. I was just discussing with Amul, another moderator, how long they do ESD for various procedures. Say 12 to 13 hours they do it, because he is an ardent clinician, researcher, and specialized in advanced interventional endoscopy. Then only you can passionately do for long hours like surgeon. He has got interest in US guided intervention, biliary drainage, and pancreatic lesions. And he has got several awards to his credit and very good publications to his credit. Amal is another eminent gastroenterologist endoscopist. He works for the Dinanath Mangeshkar, the hospital Pune. I've seen his growing from just upper GI endoscopy. Now he has become one of the international eminent faculty in the third space. He is a visiting assistant professor in the local medical college, specializes in endoscopy technique. Like apart from the regular one, he is a expert in the third space endoscopy. He has got several publications to his credit. We have PG panelist, the consultant panelist, Dr. Gokul. He is a consultant gastroenterologist at India Hospital, Chennai. Recently, he got the prize in the endo quiz competition in Medanta Hospital organized this EPL. And he has already got video champion award from Hong Kong. And next is Dr. Praveen Kumar, Associate Professor and Head of Department of Gastroenterology, Government Medical College, Kannur and Kerala. And we have our friend and trainee from Medindia Hospital, Professor Dr. Deji Ajayi from Nigeria. Apart from that, we have this time 2 PG students who are doing a fellows in gastroenterology, and Dr. The Gridhar and other doctor also there with us as a PG panel. They interact with the speakers from the postgraduate and webinar has become popular because of the various ambassadors from representing various states of our country. I just see now Dr. Ramesh Kumar and Dr. Aravind Gubi and Girish Kumar Patti and their Mahapatra. And usually we have very eminent gastroenterologists as international ambassadors also. And before I close my introduction, I just want to inform you that we are having a live workshop, part of EACG endorsement, the program. This is a due digestive endoscopy workshop. This will be next year, February 26, 27, 28. What Dr. Sridhar Sundaram and Dr. Puri going to discuss endoscopy management. You will see, witness this in this live workshop. With this, I now call upon Dr. Matthew Philip to introduce the topic, and I invite the speaker, followed by the second lecture also. Then we'll have a question, answer, and panel discussion. Thank you very much.
Thank you, Dr. T.S. Chandrasekhar, and good evening to everyone. It was wonderful. You have given a wonderful introduction to Dr. A.S. Puri as well as on the topic. And Dr. Puri is, as Dr. T.S. has mentioned, is an eminent speaker, a very good teacher, and a sought after person for giving lectures and educational activities. And at present, he has given, I think, multiple lectures on neuroendocrine tumors, and he's the apt person to discuss on that. So, Dr. A.S. Puri, please start to deliver a lecture on neuroendocrine tumors. You are muted, Puri. Just unmute.
Thank you for the kind introduction, Dr. TSC and Matthew. So I'll start my, are my slides visible, please?
Yeah, visible. Very good. Only thing is,
Okay.
yeah, very good.
So in the next 30 minutes or so, I'm just going to discuss only on the foregut carcinoid tumors or the neuroendocrine tumors because of the shortage of time. This topic is so vast that like in television serials, we'll need season 1, season 2, season 3 like that if I have to cover the entire gamut of neuroendocrine tumors. So giving you an overview, the term is JEP-NET, whereas gastroenterological pancreatic nets. So this is the broad classification. This comes under the luminal. This is pancreatics, totally separate. And today's evening, we are focused only on the GI nets, and that also on the foregut. So the vast majority of the foregut tumors are detected incidentally. And only in a small proportion, approximately about 5% of the patients will have symptomatic neuroendocrine tumors, which in the case of stomach can be either type 2 or type 3. The carcinoid syndrome is rare. And although I say it, I am going to contradict myself in a short while. So it would not be wrong to say that most of these tumors, the neuroendocrine tumors, whether we take in the stomach, whether we take in the duodenum, or even extend ourselves into the rectum, they are incidentalomas. They are detected incidentally. And this is a unique thing. For example, if you have a patient who has abdominal pain, unexplained anemia, 70 years old, and the patient has a change in the bowel habit, you know in the back of your mind that this patient is likely to have a colonic tumor. So go ahead. The patient has the symptoms, and you go ahead and do a colonoscopy, and sure enough, you find the tumor is sitting in the cecum. But in the case of the foregut nets and even in the rectal nets, you do a patient, put up a patient for endoscopy for non-ulcer dyspepsia or some non-specific symptoms. And what do? You find a tumor. And then you start looking for symptoms. And the patient really doesn't have any specific symptoms. So this is something which is quite unique to patients with neuroendocrine. Now, all of us, especially the postgraduates, when they start reading the reports derived from the path department, there'll be two different aspects to it. So I've labeled this slide as deciphering the pathology report. Now, any pathologist is going to talk about two things in the case of a neuroendocrine tumor, which is differentiation and grade. And let me make it very clear that grade is not equal to differentiation. And I'll give you the details. So differentiation refers to the extent to which the tumor morphology resembles the endocrine cells of origin. And my next slides are going to cover this point in some detail. And the pathologist is going to give you only two categories as far as differentiation is concerned, which is well differentiated and poorly differentiated. And this is an important prognostic factor because well-differentiated tumors have a much better prognosis. The grade refers to the proliferative activity, which is based on Ki67 or the MIB index, mitotic index. And here we have three categories: low, intermediate, and high grades. So low means less than 2, intermediate is 2 to 20, and high grade is more than 20. This is also an important prognostic factor because grade 1 has the best prognosis and grade 3 has the worst prognosis. So let's decipher it. You get a report, it's a well-differentiated tumor. So well-differentiated means that it looks very much like the parent cell. And what is the parent cell? The cell of origin, which is going to be my next slide, is the ECL cell. So if the tumor on the right looks exactly like the ECL cell, then the pathologist is going to say this is well differentiated. On the other hand, if it is a really distorted image of the original ECL cell, then she's going to say it's poorly differentiated. So this is the first aspect. And as far as the pathology is concerned, the pathology is going to talk about these two things, which is based now standard of the WHO since 2019. So you can have a well-differentiated tumor, which means the cells look like the ECL cells. And the grade is grade 1, which means the mitotic index is less than 2. Or we can have a well-differentiated neuroendocrine tumor with a grade 2, which is a mitotic index between 2 to 20. Next, we can have a well-differentiated neuroendocrine tumor with a G3, which means that the mitotic index is more than 20. So this cell is these cells are proliferating at a very high rate, and they are definitely going to produce symptoms sooner rather than later. And finally, we're going to be dealing with the poorly differentiated, which is also referred to as neuroendocrine carcinoma. And unlike all the others, this grade in NEC is always G3. You cannot have a poorly differentiated neuroendocrine carcinoma, which is G1 or G2. So this is the question that I ask my residents whenever we discuss this topic, that which do you think is the commonest GI net in India? And I give them the choices as is on the board. And then I show them the Indian data. Now we have 3 fairly large studies from India. This is the study from AIIMS, this is the study from Mumbai, and this is the study from Mumbai. But it also depends where the study has come from. So let us first take the AIIMS study and concentrate only on the blue. The coding for the blue is pancreas. So from a department of nuclear medicine, the commonest tumor, neuroendocrine tumor that they see is from the pancreas. Now, come again here. This is from an oncology center. And an oncology center says that the commonest neuroendocrine tumor that they see is again blue. And blue means pancreas. But if you come to a gastro department, this is from late Dr. Amrapurka's series. This is the stomach is the largest. So green stands for the stomach. And you can see that in the nuclear medicine, there were not even 11 cases, and this is at least 3 times more. The sample size is almost the same. So this is only to be expected because in gastroenterology, in the department, we are going to be doing so many endoscopic and colonoscopic procedures. And in the endoscopy, in the upper GI, we are definitely going to pick up gastric as the commonest. So the way I look at it is whenever you have to answer this kind of a question is what is the perspective? So if I was to look at this lady in red, the woman in red with a big hat, she's going to look at something like this. But if you ask a giraffe to give you a perspective and he's looking at her from above, then all he sees is this big hat with the feather. So exactly in the same way, if you're a nuclear medicine department, you're going to see more of Pancreatic, if you're working in TMH, you're going to see more of pancreatic. But if you worked in large GI centers, gastroenterology centers, which are active in endoscopy, then gastric nets are the most common. So this is just to tell you the same, exactly the same. I've already spoken about this slide, the 3 series from India. We'll skip this. Now the question comes, are gastric nets on the rise? And this was a very elegant paper that was published about 15 years ago. And they said, when you look at the data from 1950 to 1970, almost, in these 20 years, gastric nets comprised of only 2.5% of all GI carcinoids. So that is stomach, duodenum, ileum, pancreas, everything. So only 2%. Over the next 10 years, it remained more or less the same. Nothing great happened. And suddenly, the rate has gone up. So what is the explanation for this? So you see, in the 80s and 90s, that's when endoscopy started becoming popular. And after post-90, even in India, the rate of pickup of neuroendocrine tumors increased because so many centers opened up where everybody was looking at, and suddenly we would see that, either multiple gastric entities or a solitary lesion. So that is why this graph has gone up. It's not that there's an epidemic of neuroendocrine tumors in India or in the world. So when we look at the epidemiology, it's important to have the correct perspective. If I take 100 cases of gastric neoplasia, then 90% is going to be adenocarcinoma. About 4 to 5% is going to be lymphoma. And then it's going to be NET and GIST. So NETs comprise just about 2% of all gastric neoplasia. We must have the perspective right. And as I mentioned earlier, that this rise in neuroendocrine tumor is because now we are becoming more aware of these tumors. So this is, when we talk of gastric neuroendocrine tumors, we must know what is the origin. Where does the whole problem start? So as you can see that this is a gastric pit. And in this, right on top is the mucus cells. They are colored yellow or light yellow. And then we have the blue cells. There's one blue here, another blue here. Now the blue is the parietal cell. And as you know, the parietal cell secretes hydrochloric acid. Then you come down and we have the chief cells. This is again light yellow. And they secrete pepsinogen. But when we come to the base of the crypt is here. That's where you get the neuroendocrine cells. And most importantly, the chief guest of today, the ECL cells. So this is right at the bottom of the crypt. And this seems to be a little heavier cell because once it starts proliferating, it has almost by gravity, it starts falling down. And where does it go? So it crosses the musculus mucosa and goes into the submucosa. And that is why, so this is where it started its journey from. And you can see a very nice musculus propria, and it's crossed that. And now it has come into the submucosa. Now, this is what can be considered as the car jack effect. Now, if you have a flat tire, you take out your jack, and the jack is going to lift the car. And so this is what has happened. This tumor reaches the submucosa and then it starts proliferating. And when it proliferates, it lifts up the tumor. And that's how we get these polypoid tumors in the stomach, because these cells are proliferating here and they keep on pushing it up like the jack of the car. Next, I'm going to discuss a little bit about the gastric net classifications. So this is primarily based on the serum gastrin levels. If they are increased, then we are dealing with type 1 and type 2. If they are normal, then we are dealing with type 3, or type 4. So when you have a suspicious lesion, the first thing that you will have to do, one of the first things, is to find out what is the serum gastrin level. Of course, the appearance also guides you, but sometimes it may not be so obvious, and that also I'll show you. Now, for gastric nets type 1 and type 2, the analogy is if you want to make vadas, then the most important thing is the oil. Now, unless that oil is there, you can have all the batter in the world and the vadas will not be formed. So what is this oil? This oil is the gastrin. So serum gastrin level is the milieu which is necessary to form net 1 and net 2. Now, it is not important at all where the serum gastrin is coming from. It can come from chronic atrophic gastritis. There the G cells are producing a lot of gastrin, or the gastrin can be a part of the gastrinoma or the Zollinger-Ellison. But there's so much gastrin, because of this, these cells start proliferating. But when we talk of the classification, then there are essentially 4 categories, which I will discuss in some detail. Type 1, type 2, type 3, and the 4th, I've already alluded to earlier, is the neuroendocrine carcinoma, which is very poorly differentiated, which always has a mitotic index of more than 20. So the question is, which is the commonest one that even a first-year resident is going to see? And the answer is about 75 to 80% of gastric nets are type 1. Then we come down to type 3, and Zollinger-Ellison syndrome is really rare. So we hardly see, maybe in 2 years or 3 years, we see one case, so 5%. What are the endoscopic features? The endoscopic features are, because of the serum gastrin levels being so high, they are multiple, small. Small means less than 10 millimeters, 5 millimeters, both these. Type 1, type 2, multiple lesions and small. On the other hand, type 3 is solitary, just one, and the size is going to be large. And what are the associated conditions? They're going to be associated with atrophic gastritis or with Zollinger-Ellison, and no association here. Histology we've discussed, serum gastrin we've discussed. So let's go straight to METs. METs are probably less than 1%, not even 10%. I think this is an exaggeration. For type 2, 10 to 30%, type 3, more than 50%. And obviously, because of this, you can see the tumor-related deaths. In type 1, we do not expect the patient to die. In type 3 and type 4, honestly, we don't expect the patient to survive even 2 to 3 years. I think we've already covered this, that the type 1 is the commonest. So I'm going to switch this slide. Now, I told you in gastric nets, the carcinoid syndrome is very rare. So this slide was sent to me by my resident. And he said this lady came to them and she used to complain of extreme flushing. And to the extent that he sent me this picture. And they said she was malingering. She used to put vermilion from the head onto the face until it was discovered that she had a large gastric neuroendocrine tumor. I think it was it was a type 2 lesion, a large one, which had metastasized to the liver. The liver was full of secondaries, and that is why she was getting this carcinoid syndrome. So this, although most textbooks would tell you that carcinoid syndrome is never seen in type 1, but then we do see now and then. So what would be the diagnostic algorithm? In a gastric net, as I said, incidentoloma, you did the endoscopy, you did a biopsy, and you had a suspicion, and the pathologist has already given you a report that it's well differentiated, it's G1. So you confirm, you get a serum gastrin levels, chromogranin levels. And then if you think that the tumor is large enough, only then, and here I can put a very clear statement that if it is more than 10 millimeters, it is worthwhile to do a cross-sectional imaging. Otherwise, it's not required. We probably would, if it's a small one, we can skip this and go straight to EUS. which gives us a
त्यसो
lot
देख्यो
more
दिइरहेकै
immunity.
नलियो हँ
And finally, we might need to do a DOTA. I'm going to go into some
हजुर
detail
उता
about the
नत्र
DOTA
हाम्रो
later on.
माछा पनि उ गर्ने भनेको थियो त्यो माछा
So
राम्रो
what
स्टुक
are the
आएको छैन त
serological markers? The serological markers I've
बिग्रेर
already
आइहाल्यो
covered. They are serum gastrin, serum chromogranin. The rider is that if you're suspecting a neuroendocrine tumor and you want to get these tests done, then stop the patient's PPIs for at least 10 days to 2 weeks. Otherwise, you'll get a false positive. So the workup for a GNET means that you need to get 4 biopsies from the fundus because you're looking for atrophic gastritis. You need 2 biopsies from the antrum because you're looking for H. pylori. RUT would not work here. And that's the lesion over there. So you need, from that polyp, you need at least 6 pieces. And you tell your pathologist, I want not only H&E, I want the immunohistochemistry as well as the mitotic index. So, but the EUS is the best technique for the size and the depth of penetration. Now, I told you that NET type 1, multiple small. This was a solitary lesion in the stomach, and my resident said, "Sir, this looks abnormal." So I said, "Yes, it looks abnormal. You can take a biopsy." And nobody ever could think that this was a solitary lesion. It was, of course, less than 10 millimeter. And even on NBI, we could not say that this was a type 1, but that's what it was. So you can see this is in the submucosa. The whole tumor cells, monomorphic appearance, a sea of blue, and here the Carjack effect. And this is going down almost into the muscularis mucosa. This was the IHC, and this is diffuse staining with synaptophysin, which proves the diagnosis. This is just to show you what a type 3 lesion is. It's a single lesion, and it's about little smaller than the scope. Solitary lesion. So this was a type 3 gastric NET. Coming to now the role of EUS, it's most helpful in evaluating the depth of the tumor. Now, I told you that the ECL cells or these cells, they're heavy, they drop down, and mostly they would come from, on the EUS, they would be from the second layer or the third layer. They cannot arise, they cannot be arising from the fourth layer, which is the muscle layer. If the fourth layer is involved, it means that the tumor has spread now, and in all likelihood, this is not a candidate for ESD or EMR. So the EUS determines the selection of cases for EMR or ESD. And here I can say that I'm not a proponent of EMR. If you have to do it, then let it be an ESD, provided you have the facilities. This is just to show you an image of the neuroendocrine tumor from the stomach. This is a single lesion. It is arising from the third layer. It is heteroechoic, but most of it is hypoechoic, and the rest of the wall is absolutely normal. So this is not multiple. This was, again, a type 3 lesion. And if it's large enough, as I said, the cutoff is 10 millimeters. You will have to do your cross-sectional imaging. This is the axial cuts. You can see a lesion on the greater curve. And when you see on the coronal images, there it is. It's lighting up like a bulb because it is so vascular that whatever contrast you give, it'll all be gobbled up by the tumor and it lights up like a bulb. The other important test that we do, specifically, not so much for gastric, but definitely for ileal, for pancreatic, and other sites of neuroendocrine tumors, is the DOTA. And because I assume there'll be a lot of PGs sitting there, so for the benefit of the PGs, this is what a virus looks like. Now, virus is supposed to have these projections, so I've borrowed that concept. And this is actually a neuroendocrine tumor cell, you can imagine, and it has these surface receptors. And they are labeled as type 1 to type 5. So 90% of the nets will have surface receptors sticking out, like these mushrooms literally coming out. So they are sticking out. And on the neuroendocrine tumor, there are 5 types of somatostatin receptors. what the octreotide scan or the DOTA scan actually picks up is only type 2 and type 5. And that's why I put up this slide. I did mention earlier also, somatostatin expression is uniformly 100% in glucogonoma and least in insulinoma. So the insulinoma can be considered like a man who has a bald head. He has no surface somatostatin receptors. In at least 50% of the patients, 50% of these insulinomas is like a man with a bald head. So this is the principle. Now, this was very interesting. Now, this is your somatostatin receptor, and I put a type 2 receptor here. So when you give somatostatin, you inject it, it goes and binds to that. Your somatostatin, through the action of DOTA, is also bound to gallium. So gallium cannot bind somatostatin directly. But this molecule, what a unique molecule it is, it binds two things. It's like a pair of handcuffs. So it binds one handcuff, एक कड़ी जिसको कहते हैं, that is the somatostatin, and the other is the gallium-68. And this is picked up by the gamma camera. Now coming to management, it depends on the size. So if the size is less than 2 centimeters, then what are the options? Yes, surveillance is an option if the patient is 8th decade or 9th decade and has multiple comorbidities, then you can probably put him on surveillance. Or in a younger patient, you would consider EMR or ESD. Here, I'd like to mention the number. Arbitrarily, this has been fixed as 6. I will show you in my next slide. But the prerequisite for an endoscopic EMR and ESD is that there has to be no resection of the musculus propria or the adjacent lymph nodes, because this would make him a surgical candidate. And so, as I said, surveillance can be considered for patients with comorbidities. But if the size is more than 2 centimeters, very clear decision, surgery. So the candidates for EMR or ESD are the type 1 gastric nets. The size is less than 2 centimeters. They are preferably less than 6 lesions. And the depth of the tumor is limited to the submucosa. And absolutely essential, no lymph node mets. I've already covered this. So this is just to show you the endotherapy. This is an EMR being done. So this is, we measure the size. And then you put the varicose, the same thing that we use for EBL, we put a rubber band and then you clip it off. Now, there is a debate that is being considered, which is better, EMR or ESD. Hands down, if you have the facilities, if you have the expertise, ESD gives you a very clean resection of the tumor, whereas EMR is a blind procedure. It's good for beginners, but it probably doesn't do much to the patient because you could clearly leave a part of the tumor behind. So what is the follow-up strategy? The follow-up strategy, post-resection, every 6 months, you need to do a surveillance endoscopy for 3 years, and after 3 years, you can make it once a year. The survival rate. If you talk of type 1, as I said in my first slide, we expect the survival rate to be 100%. So we don't have to be too aggressive. Whereas type 3, it is probably 50-50. Now, I'm going to go on from the stomach to the duodenum. Here again, if you look at all the duodenal tumors, then neuroendocrine tumors probably contribute less than 5%. And if you look at GI nets as a whole, then duodenal nets contribute only 5%. And most of these are non-functional. And interestingly, when you look at, this is the picture of the duodenum, there is a gradient. So the commonest site is D1 and D2. And when you put these together, they would account for almost 90%. But when you go to D3 and D4, probably 5% of all duodenal nets will be in D3 and D4. So for some unknown reason, it is D1 and D2, which are the most preferred sites. The clinical presentation, again, as I said, only 5% are symptomatic. The others will all have non-specific symptoms. And functional probably 5%, at the most 10%. The commonest is gastrinoma. The others are non-functional. The gangliocytic paraganglionoma can cause extrahepatic biliary obstruction when it's sitting on the papilla, but it's not a functional tumor. It can cause obstruction, yes. And this is what the duodenal net classically looks like. It can be solitary or multiple. It's sessile, no polyp, because it's being pushed up by the car jack. It has a central umbilication, and which makes it look like an Indian mithai, which is the balushai. I'm sure all of you have seen balushais. So if you start seeing balushais in the duodenum, you know what you're dealing with. And about 15 to 20%, they can be multiple. And when they are multiple, as is shown in this case, this patient is not a candidate for either ESD or EMR. If you have adequate data on this, then probably when you've decided to go ahead, then the only thing that you have to go ahead is a surgery, and these patients should not be taken up for endoscopic procedures. Sometimes you see, again, this is polypoid, all of them. So multiple duodenal neuroendocrine tumors, again, unfit for any kind of endoscopic resection. What is important is the size. Now, if you look, almost 50% of duodenal nets are less than 10 millimeters, and only 20% are more than 2 centimeters. So when should you suspect? Can you actually suspect a patient to have just by looking at him? Yes, if a patient has a neurofibromatosis as shown over here, he is the most likely candidate to have a duodenal net. Or if you have a patient who you enter and he's been having a diarrhea, and you go in and you see all this acid burn injuries because of the hydrochloric acid, these are the patients who would have a functional duodenal neuroendocrine tumor. And classically, this is from the duodenum, because that's the islands or trabeculae having the neuroendocrine cells, the tumor cells. And this, comes from the duodenum because you can see the Brunner's glands. So what are the prognostic features? Again, size. So if you have a tumor which is more than 11 millimeter, then the odds ratio for a lymph node Mets is almost 11. If your Ki67 mitotic index is very high, then your odds ratio for lymph node Mets is almost 7. And how do you stage them? Staging is simple, because if you have an N1 lesion, that makes it a stage 3 disease. If you have M, it's stage 4. Mostly we get it here in T1 and T2 with no lymph node or no Mets. So these would be stage 1 and 2 based on the size, which I said is either less than 10 or between 10 to 20. So how do you treat them? Same as in gastric. If it is less than 10 millimeters, you can consider an endoscopic resection. However, if it is sitting right on the papilla, then you can even go ahead and do an ampulectomy. So size, if it's less than 10, you can even wait and watch. If it's more than 2 centimeters, very clear, surgery. And this is the controversial area where we can do ESD rather than EMR. But do we have to remove all the time? I don't think so. So this is just to show you one of my patients. He's about 80 years old. He has pulmonary disease. I have been following him up for 2023. And last week I saw. So nothing has changed. So I didn't want to subject him because he had multiple duodenal neuroendocrine tumors. It would have meant that he goes for a Whipple's resection or a major surgery, which he was not willing. He was not fit. So finally, the management protocol, as I said, is based on the tumor size. If it's less than 10 millimeters and on sitting on the papilla, then you can go for a ampulectomy or a surgical resection. If it is non-periampullary, then you have a choice between resection and surveillance. Here you want to go in because it's sitting on the papilla, and if it grows, it's going to cause mechanical obstruction and cause extrahepatic biliary obstruction. If the size is more than 2 centimeters, then it's very clear. You're going to go ahead for surgery unless the patient has metastatic disease, in which case you can consider PART. The controversial area is between 10 to 20 millimeters, where you have a choice between EMR and ESD. So, to conclude, the take-home message is there is a rising incidence of foregut neuroendocrine over the last 3 decades, and that's mainly because we are now more aware. The neuroendocrine tumors of the stomach and duodenum are mostly non-functional, and the risk of distant spread depends on their histological grade and size. ESD is more appropriate than EMR for foregut tumors, provided the size is less than 2 centimeters. Of course, there are people like Amol Bapai who can do bigger, but this is what is given in the guidelines. And EOS and DOTA scans are important investigations to document local and distant spread. Thank you very much, and we'll take the questions at the end of the second.
Thank you, Dr. Puri, for this wonderful lecture. It was very crystal clear, and you have made it a nutshell. And I think it was really good. I'm sure there will be a lot of questions, and TSC will have the questions at the end. Am I right?
Yeah, and then after the second lecture, so
Yeah.
now I invite Dr. Amal to introduce the topic, and I invite Dr. Sridhar for the second talk on this. I think you'll all agree with me that a lot of postgrads would have been benefited by Dr. Puri's lecture. He made it so clear, and he gave nice analogy of vada and the other thing. It made it very clear how acid can be contributing, and without acid also you can have net. Anyhow, we will discuss a lot of things, and endoscopy management we need to have more the discussion on that. So with this, now I call upon Dr. Amal to start the proceeding for the second lecture.
Good evening, TSC and all viewers, and thanks to TSC and the entire team at MedIndia Hospital for this kind invitation, and honor to be part of this, great webinar. And it is a pleasure for me to introduce the topic, Gastrointestinal Stromal Tumours, or GIS, which is a topic which is very close to my heart. And I'm even more pleased to present to you none other than my great friend, Dr. Sridhar Sundaram, gastroenterologist and interventional endoscopist, one of the dynamic, stars of, young stars of India, from Tata Memorial Hospital, who has extensive experience in endoscopic resections and full thickness resections, and in management of GIST tumors, to actually give a overview of what we know about GIST today and how it should be tackled and how these should be taken up. So over to you, Sridhar, and I hope we have a enlightening lecture from you. Thank you.
Thank you, Amol sir. I hope my slides are visible.
Yeah, your slides are visible.
Thank you,
You
sir.
have to make a presentation more.
So Amol sir, thank you for the kind introduction, and TSC sir, thank you for the lovely invitation. So I'm going to be talking about gastrointestinal stromal tumors over the next 20-25 minutes.
Can you move on to slideshow?
Just go to slideshow.
I'm already on slideshow.
No, you
No,
can.
but
No.
for some reason we are not getting the slideshow.
I'll just reshare it.
Yeah.
Can you see it now?
Yeah.
Yeah. Fantastic.
Okay. So over the next 20-25 minutes, I'm going to be talking about gastrointestinal stromal tumors. This is a brief overview of how I'm going to be discussing the topic. Now, I have prepared some case capsules, and hopefully we will cover all of these points over the next case capsules. Coming first to epidemiology, I think GIST is known to be the most common mesenchymal tumor of the GI tract. 5% of all sarcomas are GIST, and stomach is the most common site. Typically occurs in the late 60s, and like in the case of neuroendocrine tumors, a significant proportion of patients are asymptomatic. The annual incidence approximately is around 10 to 15 per million per year, but it's much rarer than the standard epithelial tumors that we encounter. So CA stomach, CA esophagus, CA colon, much lesser than that, almost 20 times lesser. So clearly, for every 20 cases of an epithelial tumor, maybe you will have one gastrointestinal stromal tumor. Now, if you look at data from India, Indian data is very limited. There are only few studies, largely from big institutes, maybe referral centers, if I can say that. Data from NIMS, CMC, JV Pant, the Cancer Institute at Adyar in Chennai, Kidwai, TMH. So they are all small series. But if you look at the data, the median age is somewhere in the late 50s. Again, most common side being the stomach. There are, of course, some differences in the studies, but I think I'm not going to go into that. Now, we should know about the origin of GIS when we talk about GIS, and that cannot be discussed without talking about this individual, Santiago Ramon Cajal. He was the one who first discovered these interstitial cells of Cajal, which are known to be the pacemakers of the GI tract, and he hypothesized their role way back in 1911. Now, secret expression in these cells was not known till the late 1980s, till the advent of electron microscopy. So we did not know that there were tumors that were actually arising from these lesions till the late 1980s. Now, this happened, I mean, they were often misclassified as leiomyomas till Mazur and Clark actually looked at the histogenesis and looked at lesions, almost 28 cases, which were classified as leiomyoma, and looked at whether they had neuroectodermal, marker expression, that is the S100 protein for schwannoma, or markers for leiomyoma. And they found that almost 14 cases did not express any of these proteins. So it was actually their seminal paper, this paper, that actually led to the term gastrointestinal stromal tumors that we use today. Now, subsequently, of course, to understand the pathogenesis, the first description of the gain of function mutation in c-KIT was done in 1998, which is basically how we came to know about the pathogenesis, wherein there is decreased apoptosis and increased proliferation. Again, PDGFRA mutations were again described somewhere in 2003. So KIT mutations are possibly the most common mutations that you see in patients with GIST. Around 80% will have KIT mutations in various exons, and a small proportion, maybe a tenth of KIT, would be PDGFR, that is platelet-derived growth factor receptor alpha mutations that you see in various exons again. And a small proportion, maybe 10 to 15%, are wild type, wherein there are no such mutations that are actually seen. Now, again, KIT, there are different exons that can be expressed in different parts of the GI tract. And again, PDGFR is largely exclusively seen in the gastric, omental, or mesenteric GIST. Now, when we talk about pathogenesis, we should also understand natural history. Now, GISTs are known to progress over a period of time. If you look at autopsy studies, you will find GISTs are very, very, very common. In a large autopsy series from the US, almost close to 8,000 autopsies, GISTs were seen in around 3% of all the autopsies. So clearly, they are not very uncommon. But the thing is that there is mitotic inactivity and tumorigenic arrest that happens at this level. And there is need for additional mutations over time, over and above c-KIT, to progress to low-risk GIST and eventually malignant GIST. So low-risk GIST would occur, in addition to the KIT or PDGFRA, if there is loss of 14q or 22q chromosomal mutations. And again, malignant GIST can be because of P53, P16, and so on and so forth. Now, much like the epithelial tumors, familial association is also known with GIST. There are germline mutations that can be seen in KIT or PDGFRA. Very similarly to neuroendocrine tumors, you can have neurofibromatosis type 1, which can have familial association with GIST. And of course, there is Carney's triad and the Carney-Stratakis syndrome. Both are very, very rare and are known to be associated having paraganglionomas and GIST. Now, we'll move over to cases and see how to approach these lesions when we actually see them in clinical practice. Now, this is a 45-year-old female, persistent upper abdominal fullness over the last 5 to 6 months. She was evaluated outside with an ultrasound, which showed a lobulated lesion in the antrum of the stomach. Subsequently, a CT was done outside, which showed a large lobulated enhancing mass lesion around 5.5 centimeter in the antrum. So you can see this lesion in the antrum of the stomach. No other lesions were identified. So what are the learning objectives from this case? We are looking at what the standard imaging is. How do we look at, a sample for tissue, any adjunct modalities that help, risk stratification, how do we do, and how do we plan treatment for these patients? Now, radiology, for CT is the investigation of choice. Contrast CT, you will typically have enhancement during arterial phase. You may have some washout. Cystic degeneration with necrosis may be seen, especially in the larger tumors, and calcification may be seen. There are two signs, the tumor vessel sign and early venous return, that is often seen in this patient. Now, tumor vessel sign is because they are very hypervascular tumors. So in the arterial phase only, they will show venous engorgement, and that is known as a tumor vessel sign and may have early venous return seen. Now, they have a predilection for the liver and peritoneal metastasis, but lymph node metastasis are very, very rare. So they are only seen in 6% of all the cases of GIST. Now, what about PET? Now, typically, most of us who have seen patients of GIST, we often ask for a PET CT. Now, FDG PET is considered an adjunct to contrast CT and not a primary modality. It can be used to clarify ambiguous findings like active from necrotic disease or malignant from benign tissue. Typically used for response assessment in metastatic disease in terms of activity on PET, and there is significant correlation between mitotic index and PET activity. So again, if you compare the modality, CT is said to be the best. It localizes the tumor, also gives us idea of the definitive diagnosis and also metastasis. Ultrasound is unreliable, has some operator skill, that is dependency. MRI typically only for rectal GIST you will be using for considering operability, and PET CT it's an adjunct to therapy, better for imaging liver metastasis than CT alone. So coming to the first core tip, CT is the imaging investigation of choice. PET CT is an adjunct for metastatic disease and response assessment for those on TKIs, for tyrosine kinase inhibitors, which of course we'll come to later. Now, what about endoscopy in GIST? Now, clearly, you're going to see these patients and you're going to, apart from an imaging, you're going to ask for an endoscopy. So you may see a subepithelial bulge in a lot of these patients. The common differential would be a leiomyoma, schwannoma, NET, so on and so forth. Probing may help, see a pillow sign and may help rule out a lipoma. Now, typically, whenever you have an SEL, these are the things that you will report: the site size, overlying mucosal integrity, ulceration, the shape, lobulation, or umbilication if seen, and the surface view. Now, all of these are critical factors to report when you're seeing a subepithelial lesion. Now, apart from just looking at the lesion, you'll also do an endoscopic ultrasound because these are subepithelial lesions. So the choice of probe, typically it can be a radial or a linear probe. A radial probe can give you good lesion assessment, staging assessment. Again, a linear probe can be used for sampling. Location intra or extramural needs to be confirmed. Addition of adjunct diagnostic modalities can be done on EUS, and sampling is typically done during EUS. Now, layer of origin, this is often a challenge. I think all of us have faced difficulties when you're looking at the layer of origin. We often feel we've totally got it, but sometimes we often get it wrong when you're actually going in to sample these lesions, or when the surgeon actually goes in. So typical layer of origin for a GIST, you're looking at the fourth layer of origin, that is origin from the muscularis propria layer you'll typically find in a GIST. Leiomyomas, on the other hand, can be layer 2 or layer 4. For optimal evaluation, we typically use a water submersion method. We evaluate from the center first without compressing the lesion, and then from either side to confirm the site of origin. So you can actually see the layers rather well. Then, of course, the echogenicity matters. So typically, GIST, you will have hypoechoic. It's typically a hypoechoic lesion, may sometimes be isoechoic as well. And again, there are some features that are suggestive of malignant GIST. So typically, a size more than 4 centimeter, irregular borders, heterogeneous echogenicity, lobulation, and cystic areas within typically suggest a malignant GIST. Now, contrast EUS can be used to differentiate leiomyomas and GIST, because GIST will have uptake and may show homogeneous or heterogeneous enhancement pattern. And there might be heterogeneous enhancement which may suggest malignancy in a patient with GIST. Elasto, it can be done. There's only one study which looked at the role of elasto. The highest value is seen in schwannoma. So typically, leiomyoma, schwannoma, and GIST are differentials, and it's often difficult to make out which is which. But schwannoma is said to have the highest value. GIST is more than leiomyoma and pancreatic rest. So it may help to some extent, but it's not going to be diagnostic. So what actually helps is tissue sampling directly. So how do you tissue sampling? We need to sample because we need to establish the diagnosis. We need to risk stratify these lesions based on number of mitosis. And sometimes we do mutation analysis, which guides treatment protocol. Now, when we are talking about sampling, the questions that need to be answered are whether we need to use EUS or not, whether we can do direct endoscopic sampling. Second, of course, the choice of needle type, FNA or FNB. Is FNB, what is the cutting edge of the needle, the size of the needle, and the choice of suction. So there is a lot of data, at least when it comes to subepithelial lesions, for directly biopsying, bite-on-bite biopsy, or single incision with a needle knife and then biopsying from the subepithelial lesion. The technical success and the diagnostic success rate is pretty high in these lesions, especially when it is endophytic. Now, we also performed a systematic review over here, and we showed that in lesions less than 2 centimeters, the mucosal incision assisted biopsy actually performs better than EUS because the range of movement for the EUS biopsy is limited. You may lose the lesion in the large stomach sometimes. So not all SCLs are eligible for a mucosal incision. Typically, the endophytic ones only we can do it. But this is a good technique, especially for the smaller lesions, if you're finding it difficult with EUS. However, EUS remains the gold standard. Typically, EUS FNB is what we will do. There's a lot of data to suggest that FNB is much, much better than FNA. Even if you're using a 19 gauge FNA, FNB fares better. What about the type of needle? I think we are all using the third generation needle now. I think the Francine and the fork tip needles are said to be the best when it comes to diagnostic accuracy. And lastly, of course, the size, the type of suction matter. To be honest, given that the needles have become so good, I think the suction has very little to do with yield these days. So what is the core tip? Again, for sampling, endoscopic ultrasound evaluation is critical in the diagnostic pathway. EUS FNB is the best modality for sampling a localized cyst, and bite-on-bite biopsy or sync can be done for endophytic lesions, if you're not getting a good sample with EUS. Now, what is the pathologic assessment? We typically look at HPR. In these patients, we do an IHC with CD117 and DOG1. Now, DOG1 is very, very specific for GIST, highly sensitive and highly specific, is said to be seen in most of the patients with GIST. Typically, there are three types: spindle, epithelioid, or mixed. Epithelioid is said to have the worst morphology. And again, we look at the Ki67 index or the mitotic index per 50 high power fields to grade which helps us prognosticate these lesions. So typically, immune markers, you'll have DOG1, then CKIT, CD34, and so on. Question is, we also send the sample for biopsy. Do you do a CKIT mutation testing in all of these patients? Typically, a patient who's going to receive targeted treatments with tyrosine kinase inhibitors, it is best to do a mutation testing. So exon 11 mutations are known to have favorable clinical course. Exon 9, on the other hand, require higher doses and may have a poorer clinical prognosis. So typically, any patient who's going to be treated with a TKI therapy, genotyping is what is recommended. So coming back to our case, now this is from the CT, the endoscopy revealed a very large subepithelial lesion in the antrum with normal overlying mucosa, like you can see. We did an EUS. You can see some cystic areas also in the EUS. It was heterogeneously hypoechoic, arising from the fourth layer. It was hard, maybe firm to hard on elastography. There was heterogeneous contrast enhancement on contrast harmonic EUS in the early phase. And we did an EUS biopsy with a 22 gauge FNB needle. Now, this is what we found. We found a spindle cell variant of GIST, diffuse CD117 positivity, and diffuse DOG1 positivity. So we confirmed the diagnosis of GIST. Further treatment, this patient was discussed in an MDT, underwent an upfront distal gastrectomy with Roux-en-Y gastrojejunostomy. Now, the final HPR, again, it turned out to be gastric GIST, 5.7 into 5.2 centimeter, no necrosis. Tumor cells are positive for CK DOG1, and mitotic count here, this is the critical factor, 8 per 50 high power fields, and MIB index was rather high. So based on site size and mitotic index, we do risk stratification for recurrence risk. Now, this patient has already undergone surgery. So the question remains, what do we expect? So do we really need to give adjuvant therapy or not? So this stratification typically is, there are two classifications. We use a modified NIH criteria. It's very easy to remember. If you go into the details of the numbers, there's only one rule that you need to remember. That's the rule of 5. Any site with size or mitosis more than 5 is considered high risk. So if you have size more than 5 centimeter or mitosis more than 5 centimeter, it's typically a high risk lesion. So it's very easy to remember, and this is what is traditionally used across the board. The second is the AFIP criteria. Now, this is the Armed Forces Institute of Pathology criteria. It's a little more complex, but looks at progression across the board from duodenum, jejunum, ileum, and rectum. They studied over 1,600 cases to actually come up with this model based on size and mitotic index and site. So again, it's the three things: site, size, and mitotic index that you're looking at. So adjuvant therapy, a lot of data to say adjuvant is good to reduce recurrence-free survival, especially OS overall survival benefit also seen. So the core tip here is that adjuvant imatinib is recommended for 3 years. So there is data to say 3 years is better than 1 year in high risk GIST based on the modified NIH criteria, which of course I've shown before, the rule of 5 with a mutational profile. So you need to do a CKIT testing before adjuvant showing sensitivity with an exon 11. Now, let's say exon 11 mutation, although it's seen commonly, is not seen. What about exon 9? Now, this is just published 5 days back in JAMA Oncology, and they showed that even with exon 9 mutations, giving a dose of 400 imatinib is good, although there's poorer sensitivity, but still there is survival benefit, recurrence free, as well as overall survival benefit. What about PDGFRA mutated GIST? Adjuvant is avoided due to poor response, and there is no consensus in a wild type GIST. So what happened in our case? It was high risk because the size was more, the mutation was high. So clearly high risk, rule of 5, it was satisfying both. We did a c-KIT mutation analysis. It was wild type. PDGFRA, again, wild type. But so clearly there's no consensus here. But considering high risk, we offered adjuvant imatinib for 3 years. What about neoadjuvant therapy? In some cases, you can offer neoadjuvant to reduce the surgical morbidity to ensure better chances of cure after surgery. So extent of surgery and nature of dissection can be lessened. So again, c-KIT mutation analysis is recommended. So based on MDT discussion and potential extent and morbidity of surgery, you can consider patients for 3-month neoadjuvant therapy with imatinib and subsequently send them for surgery. So CORTEP 4, again, neoadjuvant with TKIs is indicated after a multidisciplinary team discussion to reduce the surgical morbidity in high-risk patients based on risk of malignant potential. So again, the site, size, and mitosis index is what matters. Coming to a second case, this is a 55-year-old female presenting with dysfunctional uterine bleeding. Now, strangely, she got evaluated for that, was found to have a fibroid, but a CT was done incidentally and found to have an endophytic enhancing lesion in the stomach around 2 centimeters in size. EGD showed a small endophytic lesion in the distal body. EUS showed the lesion arising from fourth layer, and biopsy was showing a GIST. Now, of course, the learning objectives here are what are the cases that are appropriate for endoscopic resection, what techniques can be used, and how are the outcomes when we compare it with surgery. Now, if you look at the guideline recommendations, endoscopic resection is typically recommended as an alternative to surgery for subepithelial lesions less than 3.5 centimeter size. This is the ESD guidelines. Now, smaller lesions are said to have a lower risk of metastasis. They are lower risk lesions for recurrence as well, and which is why they can be amenable for endoscopic resection. Now, resection, if you look at data, although it is done for exophytic lesions as well, is largely limited to endophytic lesions. Now, in exophytic lesions, more than 1/3 burden outside the tumor walls typically is considered for surgical resection or hybrid techniques. So how do you classify this? Now, Kim gave this classification where there are 4 types. If you have a lesion that is largely endophytic, then A or B, you can go for endoscopic resection. C with some exophytic component, or D where larger part is exophytic, you may have to look for full thickness resection or hybrid techniques in these patients. Now, what are the techniques that we use for resection? I'm not going into details, but you can use exposed TFTR, wherein we can resect the whole lesion, and have a peritoneal defect, which eventually we can close by various techniques. We can do a stir, especially in the esophagus. It's a good method. So typically you can do a tunneling dissection, go above the lesion and remove the lesion through the tunnel, and again close the defect. And lastly, of course, non-exposed TFTR, typically done for very small lesions, 1 to 1.5 centimeter lesions. You can do a non-exposed EFTR with the OSCO FTRD device. Now, comparison with surgery, there is largely retrospective studies. All cohort studies, there is no large level 1 evidence, at least comparing with surgery. Now, all of them show high technical and clinical success with long-term oncologic safety for smaller lesions. Now, in all of them, the lesions were less than 4 centimeters in size in all of these studies. They all said that endoscopy has a shorter hospital stay and quick recovery. Now, the only caveat here, the endoscopy is of course performed by experts in all of these cases. Now, comparison between techniques, of course, whether we should do EFTR or STIR, whether we should do, what should we do, or, LECS, like we were discussing previously. So typically EFTR is said to have a higher en-bloc resection with better oncologic outcome in one study. But again, if you look at another study, they were similar technical and clinical success. Only thing, if you're doing a laparoscopic endoscopic cooperative surgery, the hospital stay becomes longer. So the CORTEP 5, both EFTR and STIR are safe and effective with good long-term oncologic outcomes compared with surgery in GIST less than 3 centimeters in size. Now, what are the essential considerations for patients who are undergoing, endoscopic resection? We need to ensure on-block resection involving dissection beyond the submucosal plane. So that's often challenging to identify, especially for novice endoscopists. We need to ensure that the capsule is intact. So the tumor capsule cannot be breached so that it avoids tumor spillage. If we are likely to breach the peritoneum, and closure should be appropriate and watertight after removal of the lesion. Another thing is that we should be cautious enough not to lose the resection specimen into the peritoneum. And lastly, of course, we need to be able to retrieve the specimen via the esophagus in case of an upper GI lesion. This is often challenging, especially if you have big lesions more than 4 centimeters. So what we did in this case, again, we went ahead, did marking, and did an exposed TFTR. So you can see we did some submucosal trimming, exposed the muscular layer after traction, cut through the muscular layer, and eventually creating a peritoneal defect. And the whole lesion was removed en bloc. We used an omental patch for closure with clips. So subsequently, we were able to close the whole defect with clips. Coming to my last case, it's a 51-year-old female, again presenting with abdominal pain and distension, has bilateral adnexal mass, multiple peritoneal deposits, multiple liver lesions, some ascites. Omental biopsy turned out to be a spindle cell gist. Metastatic, so the impression is that of a metastatic gist, likely omental primary, with liver mets and some deposits also in the adnexa with ascites. So the learning objectives, how do we approach these patients with metastatic GIST, and what are the potential treatment outcomes, options, and expected outcomes? So workup, baseline PET is mandated for response assessment to TKI because we are going to start them on chemotherapy. A baseline c-KIT analysis is recommended. You may do an additional PDGFRA mutation if the c-KIT is wild type. So based on the type of mutation, you can see that the response changes. Exon 11 standard dose is very, very good. Exon 9, you need to up the dose upfront, 800 mg initially. Exon 13 typically is very responsive to sunitinib. Exon 17 sensitive to regorafenib. And wild type, of course, there is limited benefit from standard TKIs, and you may have to look for alternative therapies. Response assessment, again, it's very, very challenging, especially in metastatic disease, because standard criteria, that is the RECIST 1.1 criteria that we use for most of the solid tumors, cannot be directly applied over here. So we use something called the CHOI criteria now. So CHOI criteria typically not just looks at the size of the tumor, but also looks at the tumor density in addition to the size. And we are looking at same definitions: complete response, partial response, stable disease, and progressive disease. Like I said, PET is recommended in all of these patients. So PET, typically we look at either the EORTC or the PERSIST criteria. Now EORTC uses the standardized uptake value, SUV max, for these lesions. And based on that, we look at the complete metabolic response, partial response, stable metabolic disease, or progressive disease. So again, all of these criteria are often used in studies. But if you ask a nuclear medicine fellow, they will go by visual impression. So again, visual impression while reading a PET is very, very critical. So clearly, these criteria are used for studies, but visual impression is what most experts of nuclear medicine will use. Now, when we talk about therapy, we cannot talk about therapy without talking about Brian Drucker. Brian Drucker was the one who actually came up with imatinib in conjunction with Novartis. This was initially introduced for CML, but then with c-KIT mutation being there, the first study by Michael Hendrick was published in JCO, and we were able to show response in GIST as well. So even in metastatic GIST, there was excellent response with imatinib. Subsequently, of course, the question arose, now we are doing so much testing, we're giving standard dose. Should higher dose be started in some patients? So Exon 9, clearly a higher dose, 400 BD has to be started instead of OD. And again, how long to be continued? Often patients will ask you. Now, imatinib break has been offered in one randomized trial in a French sarcoma group. Again, there was more progression when there was treatment break given. So clearly, it has to be continued lifelong. So the core tip here is that PET-CT and c-KIT mutation is a standard of care in metastatic GIST to guide therapy with TKIs. And imatinib is the first line for most cases, and it is given lifelong. Now, what is the next line if imatinib fails? Of course, if there are options of, catheter-directed transarterial therapies, typically happen for liver, you can do that. You can give some palliative radiation, but we typically moved on to we can do some dose escalation. but we often move on to the second line of therapy. That is, sunitinib, that is preferred, or regorafenib, which is third line, or ripretinib, that is fourth line. In some circumstances, avapritinib, especially in PDGFR exon 18 mutation, this is the first line therapy. Now, question is, if we start these therapies, what is the response? So 5-year OS is known to be upwards of 50%. Median survival for a patient who receives multiple lines of TKIs now is around 7.1 years. And 10-year OS is upward, it's 10 to 20%. So there is excellent survival in these patients. The problem is, of course, adverse effects. So there are some on-target adverse effects wherein there is excessive inhibition of the intended target like hypertension or hypothyroidism that can happen in these patients, or off-target TKIs because they inhibit a lot of these receptors. There may be off-target side effects like pancreatitis or cytopenias that often happen, and these need to be managed, in conjunction with an oncologist for these patients. Now, what happened to our patient? Now, our unfortunately baseline PET was negative, but the c-KIT showed an exon 11 mutation. So we started this patient on imatinib, 400 mg OD. Excellent initial response was seen. The ascites actually went away, but there was progression at 3 years. Started on sunitinib 50 mg, developed severe hand-foot reaction. So again, hand-foot syndrome. So again, dose was decreased, further decreased to 25. There was progression at 6 months. Regorafenib, again, we started. Again, dose had to be reduced to 80 mg due to refractory hypertension. Again, progression at 6 months. And now the patient is actually on pazopanib. So you can actually see that this patient, an epithelial tumor presenting with liver mets, with adnexal lesions and ascites would not have survived this long. But clearly, our patient with GIST has survived for more than 5 years. So this is a learning phase for GIST. The survival is usually very good and the response to therapies is very, very good. So to summarize, this is the most common mesenchymal tumors, but it is a rare tumor when we compare it to the epithelial tumors. CT is the investigation of choice, PET CT in metastatic disease alone. EUS plays a major role in diagnosis, FNB is for sampling. c-KIT has to be done for all patients receiving TKIs. Neoadjuvant and adjuvant depend on the risk of malignancy and recurrence, that is site size and number of mitosis. Endoscopic resection can be offered to select patients with endophytic disease less than 3 centimeters in size, and multiple lines of therapy are now available with a 5-year OS of more than 50%. Thank you.
Thank you, Sridhar, for an excellent overview of gastrointestinal stromal tumors. I think TSC, we
So
should.
the format is the first
Yeah.
moderator, Matthew, will start the question, then followed by you, Amal. And then the 3 panelists, we have Dr. Gokul, Dr. Praveen. So everyone will ask one, either make a comment or ask question. We can go for 2-3 rounds so that we'll come back. So, and before I call upon Dr. Sridhar, you did a fantastic job. But more you know, even though clarity comes, you feel that we have to know more. So last case was really, we need to know so much about chemotherapy. Probably being in a cancer center that you are able to get patients of advanced this one. You are able to have a lot of trials. I think it's a very good educational point, not only to postgraduate who have been attending now, and to even the senior consultant too. With this, I just call upon Matthew. Your comment and question to both the speakers, then followed by that.
See, is there any questions are there in the chat box or how is the format?
Actually, we already got the question which we have mailed to you, Gokul. See, the questions we have now.
And yes, Puri, wonderful talk. And you have covered everything what I really wanted to know. So there will be much questions, but just a common practice for duodenal net is to just band and leave or band and do the EMR. So what is your experience and what do you think, whether it is right or wrong or how you look at that?
If I have to say 1 or 2 lines only, then I think first it's practiced extensively, but it lacks a scientific basis, because when you are doing just a band ligation and cutting off the head, then you don't know what is in the soil. It's like a cauliflower which is growing. You're only cutting off, you're not having access to the roots. So sure enough, with the passage of time, it's going to come back to you. So I don't know whom you are deceiving, yourself or the patient. At best, it can be considered like a debulking. Yes, if that is the aim, then you can debulk it. But I don't think it has a scientific basis that you can remove the tumor just by putting a varicose, make it necrotic and it falls off, because it will just grow back. How quickly it grows back, that depends on the grade. So if it is MIB is very active, it's going to come back quite soon enough.
Okay, agreed. I think it is not scientifically proven or not, but people do practice
Matthew, I
it.
just want to comment
Yeah.
here. Puri said ESD is better than EMR. That itself is going to the one step ahead. And banding with the ligation, it appeared to be very simple, so everyone started practicing. So it may not be appropriate. Where we are doing, we have to confine ourselves, maybe where other procedures are very difficult, or maybe well differentiated grade 1, where you are likely to see that the growth is not that faster. Otherwise, doing it regularly, the banding with the EMR may not be appropriate, particularly when you have a poorly differentiated in grade 3, you should not do that.
For advanced one or grade anything above grade 2 is, I don't think there is any endoscopy resection is really suitable. It is not recommended. And one more thing is that general teaching is that any ambulatory NET needs to be surgically resected. What's your opinion?
You're asking me any NET? Certainly not. I totally disagree with this, because they are very benign, unpredictable, but in general, they are slow-growing tumors. And I give the analogy, they're like volcanoes. So, some volcanoes will never erupt. They will lie dormant for maybe 100 years. So the patient is going to die of something else. And here you're removing gastric nets and duodenal nets, which is not necessary. Only a small proportion. I think if I have to give a figure, it's only about 10% which are slightly aggressive. So those are the 10% that actually need treatment. The 90% you are just, it doesn't make any difference.
Matthew, you were asking about ampulla, no?
Ambula.
Ampullary net.
Ampullary, sorry, I didn't.
Because you said ampullary net.
No,
Okay.
I'm sorry about that. Ampullary nets, because they cause mechanical obstruction, irrespective of the size, they're going to cause. So here you can act sooner rather than later and do an ampulectomy, provided you have a good CT that has shown that the tumor does not have lymph nodes, does not have other mets, and in those patients who have deeper invasion going up to the musculus propria, then the patient has to be surgically unfit. So what you're taking care is just the mechanical obstruction to the bile duct, the flow of the bile duct. And here, if the patient has got cardiac disease, is very elderly, or has pulmonary disease, he's not willing to take the risk, the anesthetist is not giving you clearance, then you can.
And one more thing, Dr. Puri, one more thing. The threshold of surgery in a duodenal NET is much lower in an ambulatory NET. Actually, when there is ambulatory NET, the threshold for surgery is actually very low. You have to actually consider surgery when much more than when compared to other NETs of duodenum. What's the opinion, Amol?
Before you ask Amol, you see, if you are talking about specifically the ampullary, then one of the commonest tumors in the ampullary, which can be fairly large and can cause mechanical obstruction, is the gangliocytic paraganglionoma. Now, that is one that is totally benign. So here, in that case, and this gangliocytic paraganglionoma, it lights up like a 500-watt bulb. It's one of the most brightest tumors that you can see once you give a contrast CT. So here, I have no problem with doing an ampulectomy at all. And ampulectomy is curative in these patients. Over to you, Amol. Sorry for the interruption.
Okay, Amol, you want to answer Dr. Matthew's question before you start your comment and question.
Yeah, so Matthew, one thought about ampullary NETs, I fully agree with you that the threshold for surgical resection is probably much higher than an endoscopic resection, because ampullary neuroendocrine tumors typically have a higher risk of metastasis rather than the gastric or the duodenal, except for the G3 ones or this thing. Having said that, sometimes it is difficult to anticipate whether it's a neuroendocrine tumor versus an adenoma on an EUS or a side wing endoscopy, and you end up resecting the lesion and then you identify that it is a NET. The histology comes up as a NET. And in those situations, if the margins are clear, and then you can probably have an MDT, you can discuss with the patient and you can probably follow up these patients. But otherwise, if there is a preoperative diagnosis or during an endoscopy, we have a diagnosis of an NET, then probably I would rather advise surgery in these patients rather than an ampulectomy. Not only for the risk of metastasis, but these ampulectomies, if we do them, they can notoriously bleed.
Yeah.
These are very vascular tumors, and the only patient of an ampulectomy in more than 100 ampulectomies that we've done so far is an inadvertent in an ampulectomy that we had to do we did for an NET, and the patient had blood on table and had to be sent for an angioembolization. So that is what is a marker which it just gives you goosebumps at that time.
Okay, question to the speakers and moderators. We recently had a patient of NET with a lymph node. So we were hesitant to do endotherapy, and we called the oncologist. I think Sridhar also and Puri also. I just want to. So the oncologist perspective is different. He said, you remove endoscopically whatever possible, remove that. That regresses the lymph node if it is a metastatic. And then there are later chemotherapy, the regimes are available, which will take care of this. So don't condemn the just endoscopy therapy. I mean, not doing endoscopy therapy just because lymph nodes are there. So I just
I'll
want
give
to
you-
have your opinion about this.
Yeah, TSC, I'll probably just give an opinion because I have personal experience in some patients with this. So we have treated some patients who have typically been high risk for surgery in the first place, and that is the reason. But they had an NET with lymph nodes, maybe one lymph node, not a very big lymph node or multiple lymph nodes, but a single lymph node, maybe about 8, 10 millimeters, 15 millimeter lymph node in the paraduodenal or the peripancreatic area. So we've done an endoscopic resection, and we have treated 2 of these patients with an EOS RFA for the lymph node if the lymph node was more than 10 millimeters. And if the lymph nodes have been smaller than 10 millimeters, we've treated them with sandostatin LAR, with octreotide LAR, long-acting octreotide. And some of these patients are, they have stable disease at the end of 6-8 years as well. And that's, our paper is very soon expected to come in print on 157 patients of duodenal NETs and about a 10-year experience. So that's how it's coming in. So
Yeah, before we'll move on to Dr. Yes, Sridhar, you want to comment on this?
So much like Amol sir's experience, we've also had a series of patients where we've done an endoscopic resection for the duodenal nets and done a surgical lymphadenectomy as well. And on follow-up, I think I have follow-up of more than 4 years for at least 6 of these patients, where all of them have actually disease-free. So we've done endoscopic resection for the duodenal primary and surgical lymphadenectomy for the lymph nodes in that region. So just a regional lymphadenectomy, sparing the duodenum, because clearly that is the metabolic hub. So they want to spare the duodenum as much as possible.
Okay, we'll move on to now to Gokul. You have a comment and question to both the speakers and moderators.
Yeah, first of all, let me congratulate and thank both the speakers for the wonderful lecture. Professor Puri sir, your lecture was excellent. I think most of the postgraduates who are listening would have been benefited immensely by your talk. The analogy was very good, sir. Thank you very much. The vada, the volcano, and the balushahi, everything is in my mind. So my question to is, we routinely do the serum chromogranin A for patients with NET. Either they come with the report. So how do we actually go about following these patients in terms of repeating chromogranin A after treatment and all?
So the various guidelines, and they have a common pattern, but there are minor differences. So if you've done an endoscopic resection, anywhere between 3 to 6 months, you can follow up with the serum chromogranin levels. In the case of stomach, serum gastrin levels also will be helpful. And this also depends when you resect, what is the grade. So if you're dealing with a high grade, maybe you need to go in even at 3 months. So all the figures you'll find 3 months, 6 months, and you follow up these patients. But it's let me be very clear about this. You're not going to go only by the serum gastrin levels. I, as a gastroenterologist, will feel much more confident when I combine this by doing an endoscopy, that whatever I have resected in the stomach or duodenum or wherever. So I want the cushion of comfort coming from the endoscopy rather than from serum gastrin levels, because serum gastrin levels, they can be falsely elevated also, a false positive with PPIs. So I don't want to just keep on repeating serum gastrins. And a lot of these patients are on PPIs. So I would use that as an adjunct rather than as primary.
Yeah, thank you, sir.
You have a question to Sridhar Gokul?
Yeah, Sridhar, again, wonderful lecture, and you actually told about the cases, one managed with endoscopy, one with surgery, and one metastatic disease managed with chemotherapy. So my question is, we talk about this tumor spill happening during endoscopic resection or surgery, and this is considered to be metastatic because once the tumor spillage happens, there is risk of metastasis. So what do you do in a patient who has a resection, endoscopic or surgery, if tumor spillage happens, or if it is reported in histopathology subsequently, do you consider that as metastatic and put this patient on imatinib, and then for how long do we do it?
Yeah, so tumor rupture. So if the capsule rupture is, so the initial NIH criteria for risk stratification did not have tumor rupture. I think they modified it in 2008. The Fletcher criteria initially did not have it. In 2008, they modified it to add tumor rupture. So any tumor rupture, any capsular rupture is considered high risk. And all of these patients are subjected to adjuvant therapy.
Lifelong?
No, 3 months, 3 months, the 3 years of adjuvant imatinib. So it is an adjuvant to reduce the risk of recurrence. So even during endoscopy, I mean, ideally, that is what we take care. We want to keep the capsule intact as much as possible. And which is why, you want to make sure that if you don't breach the capsule, that leads to tumor spillage in these patients.
Sure. Thank you.
Amol sir, I think.
Yeah.
Amal, you have a comment?
Yeah, so, I actually, we were discussing NETs. We actually did not touch upon the gist till now, just now. So I just wanted to raise some pertinent questions to Sridhar about the gist. See, so Sridhar, I have 2-3 questions, particularly from the point of view. One is the tissue diagnosis part of it.
Right.
So when would you choose an EOS FNB? When would you do an incision biopsy? And when would you consider doing an endoscopic resection on the basis of just an EOS, and then you feel that, okay, let's get this lesion out and that kind of a thing? That's the first question.
Right.
Second thing is, what is your opinion about surveillance versus resection for lesions under 2 centimeters? Because that is where the gray area is, whether these patients should be subjected to lifelong surveillance versus this thing. And, with all due respect, your EOS, your endoscopy, the imaging, nobody is 100% sure whether we are dealing with a leiomyoma regist. And many of these patients are relatively young. And that is where the problem is.
Right.
And the third question is, what is your opinion about neoadjuvant imatinib for cytoreduction so as to subject these patients to endotherapy? We have some experience in that, and we've
Okay.
discussed this point
Yeah.
earlier, of this camera at least.
Yeah.
And so these are the points I want you to.
Okay. So first, with regards to tissue sampling, so I think US is the modality of choice. Now, in some situations, especially in the smaller lesions, often the ones that are endophytic, they are rather mobile, and targeting with US often becomes difficult. And in those lesions, you can do a needle knife incision on the endophytic component, and you can take a biopsy. So I would not recommend it as a routine. US still remains the primary modality. And it can be done, let's say you're not able to get a good sample with US, you can do a needle knife incision and take a biopsy. Second, with regards to what patient I would choose directly for therapy without a biopsy. Now, this is again a gray area. Now, typically patients that are between 2 to 3 centimeters in size, at least in our setting, if they are arising from layer 4, we have an MDT discussion and we've been taking up for resection directly. Now, we've done close to, I think, in the last year, we've done close to 10 resections that must be of a similar kind. And we've had one case that was a schwannoma. So you will have errors. There's no question about that. But then again, you're going in with the presumption that it is a GIST. So there can be erroneous diagnosis. Third, with respect,
third one, please complete.
third, with respect to the cases where there is neoadjuvant imatinib. Now, neoadjuvant imatinib, we have some experience. We've done close to 5 cases where we've given neoadjuvant imatinib, and subsequently, when the size was less than 4 centimeters, these patients have actually undergone a resection. Now, the risk stratification was done on the basis of biopsy. They are all, at least in our series, they were all gastric lesions that were there. And we were, able to close them. And in 2 cases, we actually did give adjuvant imatinib as well after resection. So there is some data on this. I think clearly you're presenting this year at DDW, sir. So I know about that data, and hopefully, I think when the paper does come out, we can also contribute together.
Okay.
But yeah,
now
we can do that.
We have Dr. Praveen to ask question. Dr. Ajayi from Nigeria. Then we'll come back to the PG panel. Then second round. Second round onwards, questions should be very brief. Answers should be ultra brief. Okay, so that we'll be able to cover other questions. Praveen, your question and comment.
Yes, sir. Puri sir and Sridhar Sundaram sir, it was nice talk as always, sir. And Puri sir has dealt the subject as if he's dealing a CPC case of chronic diarrhea as usual. And I want to ask one question to Puri sir. If the patient has multiple gastric carcinoids and hypergastrinemia, how can one differentiate whether it is type 1 or type 2?
That's a good question. But I think the simplest answer is between type 1 and type 2, is the patient symptomatic or asymptomatic? If it's type 2, the patient cannot be asymptomatic. He will have symptoms. And which is a symptom? The dominant symptom in patient with Zollinger-Ellison is diarrhea. It's first diarrhea, and after that is the abdominal pain and the recurrent peptic ulcer. So that's the simplest way to differentiate it. But if you want to go otherwise, you can test for achlorhydria. Type 1 will have achlorhydria, whereas in type 2 there'll be hyperchlorhydria. So the other thing is what is the site? So in the gastronoma, you would look for the gastronoma triangle, whereas in a patient with type 1, you're not going to find any primary tumor. So if you look for a primary tumor, you will find, although actually it's a misnomer, the gastronoma triangle is not a triangle, it's a quadrangle, because the apex is where the cystic duct joins the CBD. One of the points is the D1, D2, D3 junction. And the third point is not a point, it's a line that separates the head and the neck of the pancreas. So because that becomes a line, it's not a triangle. It's a very, very poorly differentiated triangle. That's the only thing I'm saying. We like things to be well differentiated. So if you're looking for a triangle, it's not a triangle, it's a quadrangle.
Okay.
Okay.
And Dr. Ajayi from Nigeria, can you unmute yourself, Dr. Ajayi? Your questions, and you want to be seen also, okay. Ajayi, your question and comment to both the speakers and moderators.
Let me start by apologizing for joining this very late. I had a problem with a time zone within here, Nigeria and India. So I got the time wrongly, but later I was able to hook on. So I'm glad to be here. I want to say thank you for the 2 speakers. They have done excellent job. and they have given us the updates on these two topics, which is very germane. My questions to the first speaker on the next is that in a patient that had surgery and octreotide being given, now he has distant metastasis. What can we do concerning the metastasis? Because often than not, they come back with side effects of octreotide, diarrhea, nausea, vomiting. And sometimes it's a serious issue that we can't really tackle. So I just want to ask, is there anything we can do other than surgery and giving this octreotide to address the issue of the metastasis? Thank you.
So I just wanted to ask you, what is the primary site of the tumor? Second, is it a functional tumor or is it a non-functional tumor?
It's a functional tumor.
Sorry?
Functional.
So what is it, an insulinoma? Is it a gastrinoma? Is it a somato?
Gastrinoma.
Gastrinoma.
Yes, thank you.
Well, if it is gastrinoma and you've done a surgery and now it is metastatic, if it is solitary metastasis, you can easily remove that because you've done the primary surgery already. So a second surgery can be taken up for that. But if for whatever reason the patient is symptomatic, then you will have to give very high dose of continuous PPI therapy. That is the only thing that you can do to take care of the symptoms, because you want to suppress the acid and prevent the ulcer and prevent the diarrhea.
And Dr. Ajay, you have a question to other speaker?
No, thank you.
Yeah. Okay, thank you, Ajay. Now we will move on to the PG panel. We have Dr. Sunil and Dr. Giridhar. You have a question and clarification to moderators. Dr. Sunil is from Madras Medical College, is the postgraduate student doing DM Gastro.
Yes, sir. Good evening to both of you. Thank you for the wonderful presentations. To A.S. Puri sir, sir, has EST and EMR replaced surgical resection for duodenal NETs?
The short answer is no. And certainly not EMR.
Yes.
ESD selective, yes. But again, as I said, that once you have patients who have lymph nodes, then as per the guidelines, it was discussed earlier with by the other people on the panel, that you can do a localized resection and then do a, but if you're going by the guidelines strictly, then guidelines clearly mention once you have lymph node mets, then you should go for surgery. But of course, there are exceptions to that. But as a PG, I think you should stick to the standard guidelines, which is very clear. Lymph nodes means surgery.
I think why the banding with the EMR became popular, because the duodenal area surgical morbidity is very high. So most of the patients are either unwilling or the surgeons also would like to be hesitant. So slowly what happened, in few cases, very successful to start with. Long-term follow-up, as Dr. Puri said, is not a good idea. So everyone do that. But why it became popular? Because of the stories of operation and surgical morbidity. What is your view, Amal? Why EMR? When do you do EMR with the band? I mean, the band ligation with the EMR. I will put it the other way.
Okay, so TSC, meaning our experience of duodenal NETs and even gastric NETs, but let me stick to duodenal NETs. So it is either ESD or it is just a band and leave strategy. It is never an EMR, because I do not believe EMR can tackle a neuroendocrine tumor effectively. You either tend to cut into the lesion, or you take the muscle and you create a hole out there. It's either too deep or too superficial, because neuroendocrine tumors are typically adherent to the muscle layer, even though they are not involving or infiltrating the muscle layer. And because of that, even after you put in a band or if we inject, sometimes even when we do an ESD, we realize that it is adherent. Sridhar will agree to that.
Yeah.
And we really have to dissect it off the muscle layer. And that is impossible to get it out with a band. So that is how it is. So what we do is, our strategy is all lesions 10 millimeter and above will be resected by an ESD. Lesions under 10 millimeter also, if they are solitary, they will be resected usually by an ESD only. Multiple lesions, contrary to what Dr. Puri mentioned, multiple lesions, the largest lesion, index lesion, is taken out by an ESD. Final histology confirms a G1 lesion. The rest of the lesions are banded, provided they are under 10 millimeters and left alone, and the patient is put on surveillance. If any of those lesions are more than 10 millimeters, that goes for a resection, either in the index procedure or subsequent procedure. That's how it is.
That creates some, gives a very practical solution there. So ESD or only banding, leave alone, or multiple means ESD, the larger one, wait for the biopsy, and the smaller one banding to be done. Okay, Sridhar, you wanted to say something?
Yeah. I think we practice what is very similar to Amol sir's practice, wherein if there are multiple, we'll remove the larger one and we'll band the rest. And that, I think, is the approach that we follow also in TMH. This is part of our MDT discussions also these days, wherein banding without resection has become part of the protocol, at least for patients with multiple small gastric duodenal nets.
For
So
both of you,
yeah.
Amal and Sridhar, when do you refer surgeon?
It's a very large lesion, more than 2 centimeters, and of course, beyond the scope of resection, surgery is the option.
So
But
more than 2 centimeter, you refer it to surgeon.
again depends whether it's feasible to resect or not. Even
Okay.
2 centimeters,
So you
we
will
can do a
be
DFTR and we can
you
remove it.
will be very, very
Resected larger
hard
lesions than
person
2
to refer it to
centimeters.
surgeon.
Yeah.
Unfortunately, I don't have
We've done
anyone in
full
the
thickness
panel from
resection.
surgeon.
No.
Amal, you, what is your take on when do you refer it to surgeon?
So if there's lymph node metastasis, then
Yeah.
that is a primary patient for
Primary.
surgery, not for
Yeah.
endotherapy, unless the patient is a high risk candidate for surgery, in which case we would try, endotherapy plus some minimally invasive option, but that is not ideal. I will agree to that.
Is
But
the
just tumor size is never a consideration for surgery,
Not a criteria. Yeah.
because full thickness resection, that's what I'm just hoping that our paper is about 2 years delayed, but that hopefully it should be coming
It
in
is
very
mainly
soon.
because of the fibrosis around this the net. It creates problem in delineation and the bleeding, and the chance of perforation is very high in the duodenum. And closing the perforation may be technically challenging. Because I did a lot of postgraduate watching doctors.
Yeah. So larger, the size of the lesion is actually a demarcation, and the risk factor for depth of invasion actually, and whether in a full thickness resection would be required or not.
Yeah.
So if the lesion is more than 20 millimeters, then the chance that the lesion will need an EFTR rather than ESD is much higher. So that's
Amal, Matthew here. See, I
Yeah.
think we should not actually give a message to people that small lesions in the duodenum with a metastasis should be tackled endoscopically
No.
and then followed.
That's
No,
what I
actually,
said
people
earlier.
should not.
Very clearly I said that is surgery.
Say,
That is
well,
surgery
see,
and
straight away it's surgery, and also I think I agree to other thing. Size may not be a big factor, but I think grade is an important factor. If you actually a Ka index is very high, I think I will send the patient for surgery. And also I have noticed that a lesion much beyond, very rarely you can see beyond into the D3. It becomes technically very challenging to do a resection. Many times up to the second part. It's okay. First part is much easier. And one more thing I have noticed as an endoscopist, we see more of duodenal net than gastric net. But if you now look at the oncologist, the surgeon, and generally into the referral thing, probably gastric is more. But as an endoscopist, you see a lot of duodenal net rather than a gastric net or a
Matthew,
colonic
one
net.
of the reason is gastric net. Sometimes the surgeon needs to operate, and they don't want to touch up on the duodenal net. One more the reason. Dr. Giridhar, you have a question? The postgraduate, is it there?
Yes, sir.
Yes.
Yeah, but TSC, just from the Indian data, Matthew, whatever has been published, of course, there is a publication bias because it can come from a nuclear medicine department.
Agree.
So as of now, if the postgraduates have to answer this question, they would still have to say that the stomach is
Yeah, I
much more
agree.
common
Yeah,
than
I
the
am
duodenum.
asking about our experience. You're all doing endoscopy. What do you see more? More will be duodenal net.
We say
First part.
the
Yeah,
common
I
is the
agree with
duodenal nets.
we see more of duodenal net, that I agree
Yes,
with you.
sir.
And that is more technically challenging for the
Challenge.
surgeon also to operate. They refer it to endoscopy. My viewpoint is,
Endoscopy
and
resection, I tell you, endoscopy resection of a D1 net is not at all difficult. It is actually,
no, for
unless
a
it is so
surgeon's
close to
point
the,
of view, difficult.
unless it is so close to the pylora, sometimes it becomes difficult. Otherwise, it's usually not a difficult task.
You very often do EST or EMR, Matthew?
ESD.
Yes.
Any good lesion, ESD is the first one. Probably in small cases, sometimes we just put a band. And when you put a band, if you think that your intention is actually for curative, you actually cut it. And as Amol has told, when you cut, you make a hole there, and then we close the hole in the duodenum. It is actually becomes
Usually,
a
what kind
almost-
of surgery, Amol, they do? Suppose they decided to do for D1 lesion.
So
Duodenotomy?
D1 lesion, they can do a duodenotomy and
Yeah,
do a
exactly.
primary closure. That can be done, but if it is a D2, then it ends up to be a Whipple, and that is where
Yeah,
the
Whipple. Okay,
Yeah,
Dr. Sridhar, your question, Dr. Postgraduate.
Yes, sir.
Doctor.
Regarding thanks for the class, sir. And regarding NET, should I choose patients for DOTA-PET like based on size and or K index, or should I do it for every GNet or duodenal net, sir?
Question to
And
Dr. Puri, no?
yes,
Okay.
sir.
Yeah. So for gastric nets, you would only do it if you're suspecting a type 3. For type 1, you don't need a DOTA. For type 2 also, you don't need a DOTA because you would already have that the patient is Zollinger-Ellison or gastronoma. So you would, in all likelihood, be proceeding for surgery on the basis of the CT rather than the DOTA. So DOTA is only there if you want to see there's a distant spread which has been missed.
Yes.
So for stomach, duodenum, you will hardly require it. DOTA is actually most useful in patients who have small bowel carcinoids, pancreatic carcinoids. They are the ones that you would want to do it. And sometimes for rectal carcinoids. But for the gastric, you hardly ever need to do it because they are multiple, they are small, they are subcentimetric. You can actually do away with it. But I think once we diagnose a patient on the basis of histology, most doctors do end up ordering a DOTA, which is a fact. I think that is more a fear of litigation, I can think.
Dr. Puri, any situation in NET you order for a FDG PET?
FDG PET, not really. If I would really order, if there is NEC, when the patient has gone into a NEC, then the surface receptors all disappear because they've all gone. So in that case, the DOTA would be falsely negative. In that case, you want to pick up metabolic activity, then you
Differentiation
probably,
also.
yes.
Okay, the question from Gokul and Dr. Ajay, then Sridhar, then after that, I have my own. Okay, quick.
So
Gokul, you have
I have a question to Dr. Sridhar. So, do you have experience of now resecting the tumor after putting a GERD-X device, so typically which is used for treating GERD? So, there are some case reports we say we can ligate it from the tumor, the fundal tumor especially, just by a GERD-X and then resect it later. Amal sir also can share.
I've never done it myself, but I prefer the conventional knife approach.
Amal?
Yeah, just Gokul, can you just repeat the question? I was just
For fundal gist, sir, do you have experience of now resecting it after clipping or ligating it with GERD-X device?
no. I would do a freehand EFTR.
Freehand, yeah, freehand.
You will be very free to do that. Okay, now Dr. Ajay, you have a question? Okay, now we have 5 minutes only. So this is for
Okay.
you have a question,
My
last
question again is to. Sorry.
Please carry on.
Okay. Yeah. My question is to on GIST. I want to ask the experience of the speaker concerning recurrence or relapse after surgery, and how soon after surgery do you have the relapse? Thank you.
Right. So recurrence, of course, uh, recurrence is not uncommon. Of course, high-risk patients you're going to be subjecting to adjuvant therapy with imatinib now. But then again, typical recurrences that you observe occur within the first 12 months. Recurrences are to the tune of somewhere between 8 to 12% after curative surgery, despite adjuvant therapy. So that may happen, but that will typically happen in patients who've undergone an R1 or R2 resections. Uh, I don't think recurrences happen after an R0, especially when you're in the setting of adjuvant. So if you have an incomplete resection, this will typically happen in patients where in difficult locations like duodenum, pancreatic or duodenal groove, or so those are the ones that typically have a recurrence. But otherwise, gastric, or if you have a rectal, or if you have a colonic gist, recurrences are rather rare.
Okay, now, gentlemen, we have
Thank
come
you.
to the end of the session. That we are going to have a little lighter session because a lot of people are watching all this. You are all very busy practice. I mean, in endotherapy and long hours, 12 hours, 13 hours operating, and Dr. Puri giving lectures all the time. And my colleagues are also very busy, Dr. Gokul and Praveen. So, how do you relax? I want one word or one sentence answers. When you are busy schedule or when you go home, how do you relax? Many postgraduates ask me, sir, how do you relax? You look so cool, and what is that? We'll start from Puri.
So my two relaxation methodologies, one is reading, reading non-medicine,
Oh, non-medical.
materia non-medica.
Okay.
And the other is the mountains. If I need a break, I go trek in the Himalayas. And
So you are like our superstar here, Himalaya. After one movie, you will go to Himalaya and relaxes. So you are like Rajinikanth here. Anyhow, two things very important: reading and trekking. What about Sridhar Sundaram?
So I am one who Netflix and chill. That is usually the strategy once I go home. But otherwise, I listen to music quite a bit, and usually
So
I sing also.
Netflix and a movie and music. What
Yeah,
about
music.
Amal? After 13 hours of ESD, how do you relax now?
Okay, so two things. One is music, and I play the keyboard
Oh, you
occasionally.
play keyboard. I could
Yeah, I
have
play
asked
the
you to
keyboard
bring the
occasionally.
keyboard now. I
Well,
didn't know that.
I play it only for myself. I'm not probably that professional
No,
to
we will.
play
I
this
think next
thing.
meeting
Maybe
we'll
if
have
I
the
practice
privilege.
more and if I get more time to practice more,
So
then I
listening
probably
to
will come
music
quite.
and keyboard, huh?
Yeah, and
You
I would
learned it
work
on
out.
your
I would
own?
do exercise. I would do my exercise and work out, and that's
That
something
is
which will
okay.
get my
That is
endorphins up.
mandatory. Now it has become mandatory.
Yeah, so I
So
would
it's
get my
not no
endorphins
longer.
up, and that is what is you would give me, the kick
But
back to get back to work. And these are
Gokul,
the things.
Gokul is working with me, so you shouldn't say that you don't give me time to relax. So please tell me anything else.
I listen to music, sir, Ilayaraja songs, and sometimes I remain quiet and then start meditating.
Oh, meditation and music, right. That's why sometimes I see in the chamber very quiet and meditating. Huh? Very good. What about Praveen?
Sir, I'm relaxing. I'm a singer. I'm relaxing by means of songs, Malayalam songs, sir.
Oh, okay. You sing like Jesudas?
Not exactly, sir.
See, you still haven't asked the only saint in the group, in the panel,
But
Matthew.
who listens to that when you are singing?
My family members, sir,
Oh, very good.
and
Then
my colleagues.
actually you would have told me a little earlier, then you would have made it. Matthew, how do you relax? You are managing ISG secretary, and you are managing the administration part and endoscopy. How do you relax?
I really want to relax now, but you put me into this panel, so I could not relax.
What's that?
This
Any?
was the relaxation time. See, I enjoy my time with spending with the family. That is the most important thing because very little time I get, and whatever is left when I am free, I love cooking. So I
You
just
love
get into the
cooking,
kitchen.
huh?
Yeah, much
So
my
I am
passion.
visiting Kochi next week, Matthew.
So whenever I
I
get
like to
time,
have your
I
cooking.
go into cooking.
You make
Okay.
biryani also, no?
Not really. I make everything under the sun.
Okay. What about this postgraduate, how do they relax? You must be having a hectic schedule in Madras Medical College. The Sunil and Ajay, how do you relax in Nigeria? Okay, why Ajay, while they are
Well,
coming, yeah, how do you relax?
yes. Well, sometimes I go to, during the time I'm free, I either go to gym, exercise myself, so lose some weight,
But
and
I
then
saw
play
you when
some
you were endoscopy
tennis.
training here, relaxing, singing some
Yes.
songs. Huh?
Yes.
Yeah.
I have a lot of people who wants to come to India for endoscopy training, and I'm waiting for your response. They're on my neck already.
Okay, okay. I will. That is a private talk. We'll make it. Okay, I will respond to you.
Okay.
And what is the non-medical book
Okay.
recently I've read, Puri? One word. So everyone will tell what non-medical book you have read.
Okay, since you've asked me, the most recent book, which I've now shared with Adarsh, is called Perfect Storm. And it is how the LET was formed and how the Mumbai Taj,
Taj was.
that whole, yeah, that
Oh,
whole
that
thing.
is the one recently I just purchased the book. These are what are the things about the Mumbai has, no?
Yeah, yeah. And this is
I just
written
purchased
by,
the book.
it's written by an ex RAW and Intelligence Bureau.
Yeah,
So he had access, and it's, if you read it, you must.
Yeah, it was recently released. I saw it in a Hindu newspaper.
Yes.
The
So
book review. Oh, okay. I will read it.
you have to give the devil his due. As
Okay.
far as planning for sabotage and all this is there, the Pakistanis are unbeatable.
Okay.
We
So
just can't match
I
them.
will read that book and get back to you with that. What about Sridhar? What's a book you have read?
I read two books. I read Mindset. Mindset was a good book, and I'm reading Sapiens now.
Okay, very
Yuval
good. What
Noah Harari.
about Amal?
Well, Sapiens has
You may
always
not
been
get
one of
time
my.
at all. Huh?
Huh?
You may not get time at all. Huh?
No. I used to read. I was a voracious reader at some point in time and non-medical. Recently,
Really?
it's been more academic rather than non-academic. Let me be honest about it, because then otherwise you have to compromise on your academic reading to read non-academic. But Sapiens has been something which I've read some time ago, and that's something which is definitely on the big
Okay.
these things.
Gokul, what is the non-medical book you read?
I'm currently reading a book called The Mountain is You. So it is about that hurdles is not outside you, it is only within you.
Oh, you are very philosophical. You are reading. Very good. I didn't know that.
Who's the author? Who's the author?
Brian Weiss, sir. Brian,
Hmm.
he's a psychologist.
Okay. What about Praveen? Very nice. All of you are very. These are the clues to our postgraduate how to relax and.
Yes, sir. Whenever I'm getting some time, I used to finish APJ Abdul Kalam sir's book, The Wings of Fire, sir.
Wings
Because
of
that
Fire.
was
What
really
about Matthew? Wings of Fire is very good. Matthew?
See, I don't read, nowadays I don't read any non-medical books. Mostly, recently I have gone through the Indian guidelines on pathology of IBD and versus tuberculosis, and I have completed almost 6 guidelines in the last 2 weeks. So, not completely, but I have gone through that. So, that is my
Okay.
present
Very
thing.
good. Very good. Now, the last question is what was the turning point for good professionally in your career? Puri, your answer. What is the
Sorry,
turning point in
what
your
is the
life?
question?
What is the turning point in your life, in your professional career? I'm not asking about marriage.
Turning point was that I cleared the UPSC and managed to get into Panth, which I think is a wonderful learning place.
Very good.
Everything that I learned in gastroenterology, when I finished my DM, I just had a paper degree. That's it. Everything of patient care, diagnosis, everything I learned in Panth, and that was the turning point in my career.
Sridhar, what's your turning point in your career?
I think my time at KEM, I think that was pretty much my turning point, I would say.
KEM, when you're joining for DM gastroenterology. Amal?
Well, my turning point came nearly 30 years ago when I dropped the surgical knife and took up the endoscope.
Oh, fantastic. What made you to do that?
Yeah.
Well, it's a long story. Maybe
Oh,
at some point in time, I think it's like, we'll have
okay,
a
we'll
Good
webcam
story.
discuss
It's a
session.
good story
next
over a
time.
drink, you
Long
know.
Okay, okay. What about Gokul? What was your turning point in your life?
So what I think is after complete my DM, joined you and then learned all the techniques of advanced endoscopy. That's what I
So
think.
you have learned the technique of talking also now, at least to please the master. Okay, I think that is also very important. In my iPhone, the beginning of your career, you should have a very good mentor. The mentor takes you in the right direction. So that is a very important. Most of the time in US now, also I think Amal would agree with me. They give so much of importance about mentor, and mentor also very pleased to say he is my mentee kind of thing. So that is slowly fading in Indian scenario. But when you have a practice like endoscopy, high profile thing, you need to have a mentor. What was the turning point, Praveen? Your
Sir, immediately after my MBBS, sir, I was entered into the 5-year continuous MCH in neurosurgery, sir. I did for 6 months, then I left neurosurgery and joined in PMD general medicine. That was a turning point, sir. MD
So
general medicine and
you
subsequently
left, you realized that neurosurgery will be very demanding.
it's not that difficult, that huge that I'm not, because once in every 20 days or 30 days, I'm seeing the sunlight. Only that is the difference.
Okay, right. I used to do like that in PGI. Don't see the sunrise and don't either come after sunset. That was the Matthew Philip. What was the turning point in your life?
I was so passionate about government sector in after my MD. I decided to join in a government hospital in a remote area in Kerala, that is Idiki. There was not even one doctor in the neighborhood. Then I want to work in medical college as a teacher. So after working 2-3 years in medical college, almost 4 or 5 years I worked. Then the turning point is I decided to move to private sector, because I thought the government sector was my dream and everything. Teaching was my passion, but I could not practice what I was preaching. So I was seeing patients coming with bleeding and dying, but now situation has changed. That is how I say, because I was a medicine lecturer, then I decided that I moved to a
So
private.
turning, shifting from government to private
Government to
was a
private.
turning point.
That is not a right
And
advice now, but I tell you that was my change. I moved to high-end endoscopy. I actually could go to many parts of the world, and I started practicing, introducing
very
EOS in
good. So
Kerala,
that was the
everything,
turning
third
point.
spice, everything.
Praveen, for you, neurosurgery to gastroenterology,
Yes, sir.
and Gokul joining Med India, and Amal dropping the knife and taking the endoscopy, and joining KEM was Sridhar Sundaram, and Puri turning point was joining GP. I think GP Pant. So I think we had a lovely discussion about on this NET and GST. I had a very fantastic speakers, moderators, panelists, and we could drop in a lot of postgraduate here. It was well attended from delegates from all over the world, and it's a fantastic that keeps me going there. And every month we run this webinar, and next month going to be on totally different topic, optimizing before liver transplantation and what is the post-transplant care, not to miss it. Whatever maybe you are touching knife or taking knife for endoscopy, any one of your, someone known to you will have liver transplantation. So we need to know more about it. How do they optimize and how do they take care after the transplantation? It is like I believe in the concept that you have to know everything about something in your specialty. That is your focused specialty. But you should know something about everything other than your focused area of specialty. Then you'll be a successful. With this, I'll sign off from this. And thank you very much. And I'll
Thank
convey
you.
with all your
Thank you.
regards and wishes and the thing to American College of Gastroenterology. It has been recorded. I'll send you the YouTube the earliest to you guys, so you can send it to your postgraduate and fellows for their benefit. Thank you, Matthew. Thank you, Puri. Thank you, Amal, and Sridhar, Gokul, and Praveen, and Ajay, and postgraduate. Thank you very much.